good evening. Welcome to the ACP Problem Solving Oncology webinar series on breast cancer. My name is Dr. Daniel Hughes. I'm the ACP Training Committee Chair, and I'm pleased to be able to welcome you today to our webinar series, which has been set up to essentially provide equal opportunities for trainees across the UK in both medical and clinical oncology. We plan on holding these webinars every third Tuesday of each month from 6 to 7:30 p.m. And with expert-led presentations, case discussions from trainees, and focused on a particular tumour type or topic. Upcoming sessions will cover topics such as sarcoma, lung cancer, but we're also having introductions on the new training curriculum in December, as well as a special wellbeing and resilience session in the new year. Sessions will be recorded and made available to all ACP members alongside the ACP's Problem Solving in Oncology book series, which is going to be via a new online educational platform delivered by EBN Health. So please ensure your membership and contact details are up to date. More details to follow on that via email soon. The educational content of these meetings are entirely non-promotional, but we are proud to have our webinar series part sponsored by Exact Sciences, which is the world leader in cancer screening and genomic-based diagnostics, including of the Oncotype DX breast recurrence score. We may hear about this a bit later, and more information is available on their website. We have an absolutely fantastic lineup for today's session on breast cancer with 2 expert-led discussions, followed by 2 trainee case presentations and panel discussion. It's with great pleasure that I introduce our first speaker of the evening, Dr. Alicia Okines, consultant medical oncologist in breast and acute oncology at the Royal Marsden. Dr. Okines qualified from pharmacology and medicine at Sheffield University and undertook research and specialist training at the Royal Marsden, and where she's a member now of the faculty at the ICR. Her research interests include clinical trials as well as translational research in breast cancer. And this evening she'll be providing us with an update on the management of breast cancer. So Dr. Okines, over to you.
Okay, so I've been asked to talk to you about advanced breast cancer today and the progress that has been made recently in all the different subtypes. So it's quite a lot to get through in 30 minutes, so apologies, but as I say, just stop if there's anything that interests you that you want me to talk more about, or in anything else. There's just going to be a couple of little polls in it. It's not a test of your knowledge, it's just to get a bit of information from you and opinions, so don't feel there's any pressure on it. So the things I'm going to go through, some of the new targeted therapy combinations for ER positive, HER2 negative breast cancer, anti-HER2 therapies, particularly focusing on the new treatments for the 3rd line and beyond, triple negative breast cancer, both immunotherapy and the new antibody drug conjugates, a little bit about drugs for BRCA associated breast cancer, and just finish up with what I feel are the sort of future directions in advanced breast cancer. So the first thing is, how much do you know about advanced breast cancer? So here's the poll. Not much, haven't yet done your rotation, getting there, started the rotation last month, already know everything because you completed your breast rotation in the last 2 years, or good knowledge but a bit out of date. So if you can let me know how many is at which stage, just so I know where to, just to get a bit of information from you all. So vote away, please. Okay, and Dan, do I need to press anything to get a poll at the end of that? Okay, so good knowledge but a bit out of date for most people, and about a third of you haven't done your rotation yet. Super. Okay, thank you, that's helpful. Okay, let's see. So principles of advanced breast cancer treatment. Obviously this is palliative, so we want to optimize the length of our patients' lives, but also that make sure we maintain their quality of life. We biopsy the disease at first metastatic relapse to confirm their ER and HER2 status. And the reason for that is it does change in about 1 in 8, 1 in 9 patients. You see quite a significant change, either loss of ER, gain of HER2, loss of HER2, and all of these make a huge difference as to the treatment you're going to recommend. So if possible, do biopsy. We use the least toxic treatments first, and in ER positive breast cancer, that's generally endocrine therapy. And we use monotherapy usually rather than the combination chemotherapy that you'll see in other cancers such as GI cancers. We do use a lot of radiotherapy, but mostly to manage focal progression and symptoms in the advanced cancer situation. And we do have to think about the local control if the primary is in situ, but we know that there's no benefit from routine breast surgery in advanced breast cancer from the big study presented at ASCO this year. Okay, just to highlight one area of definite unmet need in advanced breast cancer is CNS disease. And obviously you see this in other cancer types as well. If a patient with advanced breast cancer has any kind of worrying headache, persistent nausea, any neurological symptoms, they clearly need a brain scan, and ideally that should be an MRI. Because 10 to 15% of all our patients unfortunately will get brain disease at some point during their life. And this is up to half of women with a triple negative breast cancer, probably a little over half of women with HER2 positive breast cancer, and much lower in ER positive HER2 negative breast cancer. And in terms of what impact this has on prognosis, this is just from a small case series of women with a median of 3 brain metastases that were amenable to stereotactic radiotherapy. Survival's around 2 years for women with HER2 positive breast cancer and brain mets, ER positive HER2 negative a bit less at about nearly 1.5 years, and triple negative breast cancer brain mets are dismal. And similarly, leptomeningeal disease, which we see most commonly in lobular breast cancer, triple negative breast cancer and HER2 positive breast cancer, the prognosis is unfortunately very poor. So just a little bit about how we classify breast cancer. You'll know that in routine clinical practice, we use immunohistochemistry for the estrogen receptor, often the progesterone receptor, and HER2. And if we have an equivocal HER2 result, we then use some form of in situ hybridization to work out if a patient's HER2 positive or negative. But some people have done some nice gene expression profiling. This is from Chuck Peru's group nearly 20 years ago now, describing 5 intrinsic subtypes of breast cancer, luminal A and B roughly being the ER positive breast cancers, HER2 enriched mostly being HER2 positive breast cancer, but not always. And at this point, 2 subtypes of triple negative breast cancer, the basal and the normal breast-like. So these were the initial 5 intrinsic subtypes based on gene expression. And these correlated very well with prognosis. And this was on the left, you can see the Kaplan-Meier curves for time to distant metastases, which is the lowest risk of it in women with luminal A breast cancer. And at the bottom 2, the pink and the red, the basal-like and the HER2 enriched breast cancers. And similarly, overall survival on the right, the luminal breast cancers doing best. And these are old data, so the HER2 positive look as bad as triple negative, and as we'll talk about a bit later, that's changed significantly since 2003. So subtypes also change, which makes things a little bit more complicated. So if you go to these intrinsic subtypes, and you can use PAM50 or Prosigna to actually find out which subtype your patient has in their primary tumour. But when you give patients systemic treatments or the tumours change and come back as metastases, there's quite a significant shift away from the luminal A breast cancers in particular, with an increase in the HER2 enriched type in particular when you get metastatic disease. So what do we do about it? So first of all, just starting with endocrine therapy and targeted agent combinations. And I must say thank you to my colleague Steve Johnson for many of these slides. So this is a bit of a busy slide, but it just gives a little bit of background as to what happens in endocrine resistant advanced breast cancer. And these are either patients who have relapsed after adjuvant endocrine therapy or progressed on endocrine therapy. And really there's different pathways that can be upregulated. And one of the most common is mutations in the estrogen receptor. Oh, that's gone too far. Which can then cause resistance, in particular to aromatase inhibitors. So that's the most common thing we see. We also quite commonly see PI3 kinase mutations, but those tend to be there from the outset rather than acquired. And the other area is MAP kinase signaling, upregulation. And one of the targetable areas of that is where you get mutations in HER2. A lot of these other areas, unfortunately, aren't yet targetable. And in terms of ESR1 mutations, hormonal treatments such as fulvestrant can still be effective, particularly with CDK4/6 inhibitors, which we'll move on to shortly. but also new oral selective estrogen receptor downgraders are specifically being developed to work in patients with estrogen receptor mutations. So these are guidelines from the ABC3 guidelines for postmenopausal women with ER-positive, HER2-negative advanced breast cancer. And essentially, we decide how we're going to start treatment if the patient's in a visceral crisis or not. Are they endocrine resistant already? And by that, I mean completely endocrine resistant. Have they progressed straight through endocrine therapy? In which case, chemotherapy needs to be considered. But if not, endocrine therapy is the preferred option, and ideally using a CDK4/6 inhibitor, as you can see in the pink box, in the first line setting or even in the second line setting with fulvestrant. So the first targeted agent now came along in breast cancer, excluding hormone treatments, which you could argue are targeted agents as well. But the first progress really came 8 years ago with the publication of the Bolero-2 trial, which showed that the mTOR inhibitor everolimus did prolong the median progression-free survival compared to exemestane alone in women who'd already progressed on an aromatase inhibitor. So you can see the women on exemestane alone, as you would expect, pretty much all progressed at their first scan, but a few didn't. And then you add in everolimus and you did get a significant improvement in PFS, and actually with quite a good hazard ratio, 0.43. But in the follow-up of the study, there was no change in overall survival. And those of you who've used everolimus, it's not a pleasant drug for patients. There's a lot of mucositis, quite a lot of fatigue, and if they get pneumonitis, they often have to come off treatment. So it's not the easiest drug to use, but certainly the first one that showed that we could do something about reversing endocrine resistance, at least temporarily. But what's really changed things is the CDK4/6 inhibitors, and with those have now been around for the last 5 years, and that's been a huge progress. We know that growth of hormone receptor positive breast cancer is dependent on cyclin D1, and that's a direct transcriptional target of the estrogen receptor. The cyclin D1 then activates cyclin dependent kinases 4 and 6, and that then results in the G1 to S phase transition, entry into the cell cycle and cell growth. And we know that a resistance to endocrine therapy is often associated with dependence on cyclin D1 and CDK4 and 6. And so this was a very logical target for drug development. So we have 3 different drugs, palbociclib, ribociclib and abemaciclib. You can sort of see on this that palbociclib and ribociclib are quite similarly structured, the abemaciclib a bit different, and also in terms of their selectivity at CDK4 and 6. That there's a slight, some difference, but particularly CDK2 and 9 abemaciclib is a greater target for those. So what have we seen in the trials? Because now we're several years out of these trials. So in the first line setting, combined with an aromatase inhibitor compared to the aromatase inhibitor alone, we see significant improvements in progression-free survival with palbociclib in Paloma-2 on the left, with ribociclib with MONALEESA-2 in the middle, and with abemaciclib MONARCH-3 on the right. And the hazard ratios are all fairly similar, 0.5 something. So similar benefit that we can see across the 3 drugs there. And in pre-treated advanced breast cancer, so this is the second line setting, or women who've progressed on an adjuvant AI, again, MONALEESA-3 with ribociclib on the left, abemaciclib in the middle, and palbociclib on the right. Very similar looking survival curves, but slightly different hazard ratios here, but not a lot of difference between the 3 of us, but the 3 of them. But what you can see is a big difference in the median PFS with each drug. So in the MONALEESA-3 trial with placebo, the median PFS was just under 13 months, progressed to 20.5 months with the ribociclib. With abemaciclib, the median was 16, a median 9 months increased to 16. And in the Paloma-3 trial with palbociclib, the median for the fulvestrant alone was actually only 4.6 months and extended to 11.2 months. And we know there's quite significant differences in the toxicity between the 3 drugs. Ribociclib, you have to monitor for long QT. Abemaciclib, there can be significant diarrhea. Palbociclib, most likely to give you neutropenia, although that's usually uncomplicated. So overall survival data in the second-line setting now are also available, and we've seen significant prolongation both with ribociclib and abemaciclib, and within an endocrine-sensitive population with palbociclib as well in the Paloma-3 trial. Again, some differences in the median values. So just a bit of opinion here. Which is the most effective CDK4/6 inhibitor in pre-treated metastatic breast cancer? Is it ribociclib with the longest median PFS? Because Dennis Slayman surely can't be wrong. Is it abemaciclib, where we've seen the longest overall survival? Is it palbociclib, because that's the most widely used? Or is there no difference? What do people think of this? Okay. No difference for the majority. Great. Okay. So I think that's probably true. Certainly when although the median PFS, you saw much better values with the first two drugs, actually you have to look at the median PFS in the control arm, and that reflects the level of pre-treatment within the studies. So the MONALEESA-3 were the least pre-treated with the longest median PFS in the standard arm as well, the control arm as well as the experimental arm. And the Paloma-3, many of those women had chemotherapy already, unlike in the other two trials. So absolutely, I think they're pretty much similar. There, of course, are some differences between the drugs, and the main thing is tailoring it to your patient. If you've got a patient who is not going to manage the neutropenia, then palbociclib is probably not the right one for you. And if it's someone with GI problems already, abemaciclib is not the kindest option for them. So more recent to the CDK4/6 inhibitors, and this is something we're likely to all be using soon in the post-CDK4/6 inhibitor situation, is Alpolisib, and that's an inhibitor of PIK3CA. So there have been a number of PI3 kinase inhibitors developed over the years, and initially the first ones were really plagued by problems with psychological side effects and even suicide in patients taking these inhibitors. Alpolisib is an alpha-specific PI3 kinase inhibitor, and the SOLAR-1 trial has been published in the New England a year ago, and we just had the overall survival data presented at ESMO last month. So this is the PFS in patient in the cohort with PI3 kinase mutations, because clearly you need to have the target for this to be an effective treatment. This is added to fulvestrant in the post-AI setting, and you can see a significant prolongation with a hazard ratio of 0.65. In terms of overall survival, well, apologies for the ESMO slide, but no significant difference, although numerically longer overall survival with the Alpolisib combined with fulvestrant. And this has now got a European license, and it is available through a compassionate access scheme in the UK, but you do have to fund your Guardant 360 to get your PI3 kinase result. So moving on now to HER2 positive breast cancer and the anti-HER2 therapies. I'm not going to go all the way back to Herceptin, but it is important to remember the progress in the last 10 years, and a huge part of that has been pertuzumab added to trastuzumab and docetaxel in the Cleopatra trial, now published 9 years ago. So what does it do? So pertuzumab is also an anti-HER2 antibody, but slightly different to Herceptin in that it actually prevents dimerization of HER2 with HER3, and that's the most nasty dimer, the most mitogenic in cancer cells. And if you can prevent that dimerization, it has a significant effect, and you can see the response rate from first-line chemo plus Herceptin goes from 70% up to 80% with the addition of pertuzumab. Your PFS, you get an extra 6 months, and your overall survival, you get an extra 16 months. And look at that, a median survival of nearly 5 years for advanced breast cancer. So massive progress with the Cleopatra trial. And not long after came the Amelia trial, TDM1, fantastic bit of bioengineering, taking Herceptin, bolting on chemotherapy, so that you've got a targeted way of delivering chemotherapy. And for us in breast cancer, this was the first, and obviously there have been many antibody drug conjugates come along since in other tumor types as well. So at the time, the standard of care in the post Herceptin docetaxel situation was capecitabine and lapatinib. not a particularly effective combination, but what we had at the time. And then TDM1 showed a significant prolongation of PFS from 6 to 9 months, but overall survival an extra 6 months of life, and a significant increase in your response rate as well. So off went the Paclitaxel from the Cancer Drugs Fund, and on came TDM1, and that's now NICE approved for us. But what you do next after TDM1 has really been a problem until very recently. So after this, we rather run out of HER2 targeted agents. We end up with capecitabine, and everything gets a bit miserable. So what we have now are some other HER2 TKIs. Lapatinib was the first generation, neratinib was the next one that came along, and is significantly more effective than capecitabine and lapatinib, as shown in the recently published NALA trial. So very effective, but severe diarrhea in about 30% of patients, and therefore you have to use prophylactic loperamide, which is a bit miserable because neratinib is 6 tablets a day. You add in two loperamide 4 times a day as well, plus your capecitabine 3 or 4 tablets twice a day, and it's a lot of tablets for patients, but it's an effective treatment, and importantly you get response rates in the brain of up to 50% with this combination. So it's an important bit of progress. Overall survival, there was no significant difference in that study. And at the end of last year, we had the HER2 CLIMB trial presented at San Antonio, and the HER2 CLIMB trial was investigating tucatinib, a pan-HER inhibitor, which added to capecitabine and Herceptin, so slightly different from the NALA trial. Compared to capecitabine and Herceptin alone, showed significant prolongation of PFS, and also overall survival and response rate. And what was, I think, unique about the HER2 CLIMB trial was it allowed patients with brain mets, including untreated brain metastases, so those with active brain mets as well, and progressing brain mets as well as those with treated and stable brain mets. And that was really an important step forward in this tumour type, whereas we've said over half of women will get brain mets. So that's the overall survival, with really significant prolongation there from 17 to 22 months. And as I said, really beneficial in the brain as well. And so really good hazard ratio 0.32 for CNS progression-free survival, and hazard ratio 0.58 for overall survival in patients with brain mets. So the other thing that happened at the end of last year was the DESTINY-Breast01 presentation and publication. So trastuzumab deruxtecan, or DS8201A, or they finally come up with TDXD, which is a little bit easier for us all. And this was a phase 2 trial, but just look at that waterfall plot. It's just not something that we see very often. It was 170 patients, and you saw a response in almost every patient. And these were women who'd had a median of 5 lines of prior chemotherapy. And yet you had these fantastic responses. So the median PFS was 16.4 months, and this is a topo 1 inhibitor payload. And what's different to this than TDM1 is there are an average of 8 molecules of the drug added onto each antibody, compared to 3 to 4 with TDM1. So it's a bit more toxic, but it's also significantly more effective. The only issue in the trial was the interstitial lung disease, and that was over 13%, but it probably wasn't either recognised or treated very well in that study. So hopefully in the randomized trial that will follow, we will see a lower rate of that. And this has been FDA approved, but not yet available in Europe. So that's really what we've seen recently in HER2 positive breast cancer. There are some other TKIs that have been developed in China. They're highly toxic and unlikely to be something that we'll ever be using, so I haven't gone into those. Moving on to triple negative breast cancer. So going back to those intrinsic subtypes, the basal and the non-basal, which someone decided to then make that into 6 different subtypes, just to confuse everyone. And then we've ended up with 4 subtypes: the basal-like 1 and 2, the mesenchymal type, and the luminal androgen receptor type, which is actually more of a luminal not hormone sensitive, but potentially androgen receptor targeting sensitive group, with a better prognosis and a slightly slower growing cancer than the basal-like cancers. So immunotherapy was looked into because we see a reasonably high rate of PD-L1 expression in triple negative breast cancer, around 40% depending on your assay. And so a number of studies with pembrolizumab as monotherapy, And as you can see, the median PFS is pretty dismal, about 2 months in each setting. The response rate definitely best in the third trial, the Keynote 086B, in the untreated patients. So you see a real reduction in the benefit as you go through the lines of treatment. And so this has led to first line trials, but in combination with chemotherapy to try and get better response rates. So Impassion 130 was the first past the post. Atezolizumab, the anti-PD-L1 antibody, combined with nab-paclitaxel or Abraxane, and we know that it prolongs overall survival in PD-L1 positive patients. Nab-paclitaxel was chosen because it doesn't inhibit immune-mediated effects of atezo, and there's no steroids required to go alongside it, unlike normal paclitaxel. So this was the publication from Peter Schmidt from Barts 2 years ago now, showing significant, and importantly, the Roche SP142 assay has to be used for atezolizumab. And unlike a lot of cancers where it's the PD-L1 positive cancer cells, this is actually the immune cell infiltrate that's tested for breast cancer. And about 40% of the patients enrolled were PD-L1 positive. In the intent to treat population, because it wasn't selected by PD-L1 status, there was no significant difference, or just a significant difference, but an extra month and a half median PFS. Whereas if you selected out the PD-L1 positive patients, you saw those survival curves separate as you'd expect, with a hazard ratio of 0.62. And overall survival, this is slightly busy from the follow-up publication, but if you concentrate on the blue line at the top, which is the atezo nab-paclitaxel in the PD-L1 positive, and the red line at the bottom, the placebo plus nab-paclitaxel in the immune cell positive patients, and you can see there was a significant improvement in overall survival in the PD-L1 positive patients. Important just to say that not all PD-L1 assays are the same, and this is a comparison presented by Hope Rugo last year of the Roche SP142 antibody and the Merck antibody, the 22C3 or CPS1, and just to show that there actually isn't a lot of agreement between the two antibodies. So you have to match your antibody to your treatment. The Keynote 355 study was chemotherapy versus pembrolizumab plus chemotherapy with placebo, 2-to-1 randomization, and the chemo could be gem-carbo, it could be paclitaxel, or it could be Abraxane. They looked at a number of different subgroups, the different PD-L1 cutoffs, and the CPS1 was 75% of the patients, but the CPS greater than or equal to 10% was closer to 40% of the patients, so more akin to the Roche study, number of patients PD-L1 positive. And the progression-free survival was significantly prolonged, but interestingly, much more in the taxane groups and the gem-carbo group, in which it wasn't significant. And really just going back to that, I think I must be missing a slide in there. So there was significant prolongation of progression-free survival. We don't yet have overall survival data, and it hasn't yet been published. So these are from ASCO in this summer, and really just waiting for that to see if that's going to be an option for our patients as well. More recently at ESMO, the Impassion 131 study tried substituting paclitaxel for Abraxane as a more real-world option because Abraxane is so expensive. The trial design was otherwise unchanged, and bizarrely it was completely negative with no difference even in the PD-L1 positive population. And everyone's really still chewing this over as to why it is. It's most likely something to do with the steroids required for the paclitaxel, but it is a bit strange. No difference in overall survival in the PD-L1 positive or intent to treat, and actually in the intent in both situations it looks like patients did slightly worse if anything, although that wasn't significant. So in contrast to that, there was one bit of good news at ESMO, which was sacituzumab govitecan, or SG as people are now referring it to, because that's a ridiculous mouthful, in refractory metastatic triple-negative breast cancer. So this was a study where the phase 2 was published just over a year ago, 108 patients with a median of 3 prior lines of chemo, and quite a nice looking waterfall plot, certainly not like the TDXD, but still a nice looking waterfall plot of responders in this situation. In the heavily pretreated triple negative, this is big progress. So a randomized trial followed, the Ascent trial, which some of you may have been involved in, randomizing patients between physicians choice chemo and the sacituzumab, with a significant prolongation of progression-free survival from 1.7 months with chemo, which says a lot to us all, up to nearly 6 months with this antibody drug conjugate. And overall survival, importantly, also almost doubled in this situation. So this has now got FDA approval, and we're waiting to get it in Europe as well. So this is going to be something coming for our patients, hopefully. In terms of side effects, ultimately this is just chemo given them in a bit more clever way. There's a fair bit of diarrhea, a fair bit of neutropenia, fatigue and alopecia. The one good thing is that it doesn't cause peripheral neuropathy, which actually in breast cancer patients who've already received Paclitaxel, Eribulin, maybe even Vinorelbine, this is quite important. Very brief word, because I can see I'm running out of time, on BRCA-associated breast cancer. Obviously, we don't have quite the same situation as ovarian cancer, but we do know that you can get responses in women with germline BRCA1 or 2 mutations with drugs such as Olaparib, and very similar benefit in whether they're BRCA1 or 2 mutations. And this led to phase 3 trials, first of all of Olaparib, the Olympiad trial, compared to standard chemotherapy, significant prolongation of PFS, hazard ratio 0.58, and similarly the Talazoparib trial, same situation, significant prolongation compared to chemotherapy. Importantly, in neither trial was chemotherapy allowed to be a platinum, but nonetheless an effective treatment. And we're still waiting for the NICE single technology appraisal of both of these drugs to come through. They're licensed, just unfunded, but can be applied for to both companies for compassionate access if you've got a patient who might benefit from that. So coming towards the end now, and apologies, it's been a bit of a whistle-stop tour of breast cancer. Just a little bit about where we're going. Liquid biopsies are something that obviously are far more patient-friendly than sticking needles into their liver. And we now have commercial assays such as Guardant 360, Foundation Medicine, that are ways that patients can, if they have £2,000 to spare, have their circulating tumour DNA profiled. And we know, yes, this can be done in a wide range of cancers, but in breast cancer, at least 90% of patients will have a successful test. The UK plasma match trial, which many of you may have taken part in, has just been published in the Lancet Oncology, and essentially took women who'd had 1 or 2 prior lines of chemotherapy, did the circulating tumour DNA profiling, and depending on your mutation, matched you to a treatment. The best responses we saw were with neratinib, the Her2 TKI for women with Her2 mutations, only 2% of all breast cancers, but higher in certain types like lobular, and the combination with fulvestrant gave you a response rate of 25% and some really durable responses. AKT1 inhibitors, PARP and ATR inhibitors hasn't yet been published, and we did try escalated fulvestrant in women with ESR1 mutations, but it was not particularly successful. So hopefully this is something that's going to become available to patients. We've also run the CTRAC-TN study in women after early breast cancer triple negative breast cancer treatment, doing ctDNA surveillance. And there was a planned study called TRAC-ER, which will be looking for asymptomatic relapses in early breast cancer. And a quick plug for the FAME trial, where we'll be randomizing women who are on treatment with fulvestrant and a CDK4/6 inhibitor, and if they're not getting good suppression of their ctDNA, we'll be adding either ipatasertib, the AKT1 inhibitor, or placebo. So in conclusion, I think we've made significant progress with the trials, certainly in the last 5 years, and in the last year or so. The CNS disease does remain an area of unmet need, because obviously whilst radiotherapy is a good treatment, there is always a point where there's no more radiotherapy possible. And I do think future treatments should be determined by liquid biopsies. They're much more patient friendly, and I'm going to finish there. Thank you.
There's a lot of discussion about CDK4/6 inhibitors, Alicia, and obviously there's lots of trials and probably no head-to-heads likely. So how as trainees do you think we can start to kind of pick these trials apart and really understand which one to give to patients?
I think in honesty, there's not a lot of difference in the efficacy between them in the advanced disease setting. As we'll probably hear from Judy, it's going to be different in the adjuvant setting potentially, but in the advanced disease setting, the efficacy is really quite similar. If you look at the hazard ratios, I think that's the important thing, is that magnitude of benefit is what your hazard ratio measures, and that's really similar between the three. For me, the toxicity is what helps me choose. If you have got a patient who's got a lot of bone marrow disease and therefore their counts are really struggling, palbociclib is going to be really difficult for them. But equally, you know, abemaciclib, certainly a lot of the presentations are focused on women with visceral disease and the response rates in that, and some people would follow that if you've got a patient with a higher burden of disease, they might use abemaciclib. I've used palbociclib in women with lots of liver mets without any difficulties. So I don't think there's a lot for efficacy really to tell between them. It's more about the side effects and management of those.
Yeah, are there any particular patients that spring to mind that as trainees we need to be aware about and consider toxicities and dosing, I guess, as well?
Yeah, I think so. And I think particularly, as I say, women with a lot of heavy bone marrow infiltration whose counts are struggling to start with, you definitely think very carefully about whether to use palbociclib or even ribociclib, because the rates are lower with lowest with abemaciclib. And anyone who's got pre-existing GI problems, you know, Crohn's disease, diverticulitis, whatever, you know, it's not going to be the right thing to give them a drug that causes a lot of diarrhea, or can do. It doesn't in everyone, of course. You can also get, it can be a bit confusing because of the impact on creatinine excretion. You get a rise in creatinine on abemaciclib. It's not impaired renal function, but that can be, so if you've got someone with a bit of renal impairment, I wouldn't personally use abemaciclib more, just because it's more difficult to monitor what's going on with their kidney function. So I've used palbociclib in women with significant renal impairment, obviously within the license. But
okay, great. We've got one question as well about, do you know of any data of immunotherapy with VEGF trials published or coming out?
No, not in breast cancer, because the difficulty obviously within breast cancer is bevacizumab was heavily investigated, briefly FDA approved, is still licensed here, but really rarely used, because although the first study with Paclitaxel showed significant prolongation of PFS, all the studies that followed were negative, and obviously bevacizumab isn't without its side effects. So VEGF doesn't seem to be a particularly important pathway in breast cancer. There was a significant increase in the response rate in triple negative breast cancer with Paclitaxel, so sometimes in the private sector it's used there, but I don't think we're probably going to see a lot of there are some trials, I can't think what the name of it was, there was a big sort of umbrella study using all different immunotherapy combinations that Peter Schmidt was running at Barts, and I think there was some bevacizumab in there because it was in triple negative, but because bevacizumab isn't really used in breast cancer, or nor are any of the VEGF TKIs, I don't think that's probably going to be a combination that we use much of.
So it's with great pleasure that I now introduce Dr. Judy King, consultant breast medical oncologist at the Royal Free London. Dr. King qualified from Cambridge University and Guy's and St Thomas's back in 2001. She undertook her specialist training in London, completing a PhD in T-cell immunotherapy in 2008. Additionally, she undertook a Darzi Medical Leadership and Management Fellowship, as well as a postgraduate qualification in business. So she has lots of management leadership roles, including as Oncology Training Director at Royal Free. Her research interests include combinations SACT with novel therapies, such as immunotherapies and HER2 agents. And this evening, she'll be presenting an overview of new adjuvant and adjuvant therapies in breast cancer.
Hello, good evening, everyone. This is super exciting. I've just had a look down the attendee list, and there's a bunch of people in Scotland that I haven't seen for ages. So this is possibly the first time I've been pleased to be doing this over Zoom. So hello, everybody up and down the country. Thank you for joining us out of hours. So, and thank you to the organisers. Oh, that's how I'm going to move on, for asking me to speak. I'm going to do early breast cancer and really focusing on the chemotherapy updates in the last couple of years, because there have been quite a lot of changes. So what I'm really focusing on in the early breast cancer setting, it's about who do we escalate and who do we de-escalate? Can we select patients who are more likely to be at a high risk of recurrence, who need more systemic therapy to reduce the risk of the cancer coming back? And equally, can we identify those low risk patients who really don't need all of those toxicities. And when we're thinking about quality of life and survivorship, so one of the things that probably will have changed if you haven't done breast cancer in the last year or two is the shift towards neoadjuvant chemotherapy. And one of the reasons that we do that is to escalate treatment and to see if we can achieve a PCR, or a pathological complete response. And so that has really become the focus for a lot of what we do in early breast cancer. So I'm going to focus on that and not go through all of this, but just sort of see how that relates to triple negative and HER2 breast cancer in particular. I'm not really focusing on ER positive tonight because all of the endocrine stuff is really a talk for another day. So our standard treatment option in early breast cancer is an anthracycline taxane combination. So EC Taxol or FEC-T if you're still using that. In terms of de-escalating, you're trying to identify sort of lower risk patients, and then you might give them less chemo, no chemo, or potentially less HER2 therapy. And conversely, those patients that you might want to escalate, your options lie between either accelerating the chemo, and that means if you're giving chemo standardly every 3 weeks, you just take those same drugs and book them into chemo unit a week earlier. So you give the same stuff 2 weekly rather than 3 weekly. There is a survival advantage there. I lost the slide earlier in the day, but you'll just have to take my word for it. So you either accelerate the chemo, plus or minus add to that anthracycline taxane backbone. And you would do that if you think they're at higher risk of recurrence and that the risk of their cancer is higher. So will outweigh they will achieve the benefit of that additional toxicity. So young patients, grade 3, bigger cancers, node positive cancers, or if you give them neoadjuvant chemotherapy and they don't achieve a path-CR. So quick word about why we would give neoadjuvant. I think, if you use PREDICT or one of those tools like that, if you have a patient who's at higher risk of recurrence and you would offer adjuvant treatment, then it is reasonable to offer it neoadjuvantly. One of the reasons you might do that, particularly in a young patient or a triple negative patient, is if they're waiting for their BRCA test, and that might mean that they'd have a mastectomy instead of a wide local excision. Then if you give the neoadjuvant first, it gives the surgeons a bit more time to decide what kind of flap they're going to do from which where. And
Judy, what do you mean by young? We've got some questions on the chat.
Anyone younger than me, definitely. So I think that young for me in a chemotherapy setting is certainly anyone under 60. But if I'm talking about young women for genetic testing, it's according to the genetic guidelines of, how young they are when they get their cancer and their family history, and have they got an ovarian cancer in the family. And so it's young with genetic risk. Downstaging from a mastectomy to a wide local excision might be a reason. That doesn't happen very often, actually. That's about 1 in 4, 1 in 5 you'll actually downstage. Sometimes we've got drugs that we can give in that setting that aren't otherwise available. But increasingly, it's about this prognostic usefulness of the PCR, depending on the breast cancer subtype. So Alicia talked about this before. We've got your different breast cancer subtypes, and you'll remember that the luminal subtypes are more endocrine sensitive, and the HER2 and the triple negatives are more chemosensitive. So if you give a load of neoadjuvant chemotherapy and then look at whether or not under the microscope, is there any cancer left? Blue line is they've achieved a path-CR, yellow line is they haven't. So in the luminal breast cancers, which are more endocrine sensitive, the path-CR doesn't really seem to make much difference. But if you look in those chemosensitive subtypes, the HER2s, the triple negatives, there's a massive difference in the proportion who are disease-free in the blue line who do achieve a path-CR and the yellow line that don't. And so what we're really doing is trying to do something to achieve, like push people into the blue line category. Looking at triple negative, it's actually a little bit more in depth than that. So it's not just path-CR or not. You can also look at what's called the residual cancer burden. So this is a sort of 0, 1, 2, 3 score, depending on the amount of cancer that's left. And it's a case of the more that's left, the worse it is. So what that means is that for triple negative and HER2 positive cancers, whether or not you achieve a path-CR after primary chemo strongly impacts on prognosis. And what that means for clinicians is that we are therefore chasing this holy grail of path-CR, and we will escalate therapy in order to achieve it. And also, if we don't achieve it, we'll escalate treatment further in the adjuvant setting if they failed to achieve a path-CR. So the first example of this in triple negative breast cancer. So remember your standard anthracycline taxane backbone. And the first thing we've done in terms of escalation is to add carboplatin. The main reason was from the brightness study, which was really looking at veliparib, a PARP inhibitor, and that bit was negative. So you can ignore that and just focus on the bottom two arms, which are essentially AC Taxol versus AC Carbotaxol. And this is the PathCR outcome. So you can see that in red, you've got an increase in pathological complete response with the addition of carboplatin. So it's gone up to over 50%. And that's been seen in other studies too. Bear in mind, so for me, that's practice changing data. So if you can increase the PathCR rate by what, 30, I can't even do the math, a lot. That is a big increase in PathCR. So that we have brought this in, and for us, this is now standard of care in young women, node positive women, bigger cancers. But you do have to bear in mind that if you add carboplatin, you're going to add more toxicity. Some people are going to have more neutropenia, which means doses delayed, which means doses reduced. And so you do need to be a little bit careful about whether or not people can take that additional chemotherapy. I would say that, I know Alicia uses it too, but I would say if you ask people up and down the country, this isn't 100% standard of care. So depending on where you work, this may or may not have been brought in yet. Looking to the future, we've got, so if you say that EC Carbotaxel is the standard of care for a high-risk triple negative, the next question is, well, we know, and Alicia mentioned in her talk, that immunotherapy plus chemotherapy is useful in metastatic triple negative, so does it work in early breast cancer? So this is the Keynote study, which is essentially EC Carbotaxel neoadjuvant chemo plus or minus pembrolizumab, and it's a year of pembro in total. And essentially you have an increase in PathCR again, so a 13.6% increase in PathCR, which you would think, well, if we're leaping on the carbo bandwagon, is that good enough to add pembro to everybody as well? Well, firstly, it's not available yet, so we are waiting for sort of event-free survival data and so on to mature. And this, so, and it will be interesting, but I think this is coming down the track. I put up the toxicity data really just to sort of point out the IO toxicity, because everyone knows you give chemo, you'll get the chemo toxicity, but eventually it wears off. With IO, as you'll know from other tumor types, a small proportion will get a significant toxicity, and some of that will be a lifelong toxicity. And while in the metastatic setting, you know, people might have an awful lot less to lose, in the neoadjuvant setting, where 50% of patients were going to get that PathCR without immunotherapy, it would be really nice if we could identify the people that need that additional 13% uplift, because to give 100% of patients immunotherapy when half of them don't need it is quite a big call. So the immunotherapy related toxicity is here, grade 3 and about 13%. It was a bunch of things, often endocrinopathies and skin reactions. So I think when this does come in, this will be something that, you know, the discussion with your patients about what kind of risk they're willing to accept will be a different discussion. So all very well if you achieve a PathCR in triple negative, but what about this group that don't? We know that they do badly. So how can we escalate further for them? There is one study called the CREATE-X trial. This was performed in patients with residual disease, and they were randomized to 6 months of adjuvant capecitabine, quite a high dose. And it's not brilliant here, but essentially what you're seeing here is the disease-free survival control versus capecitabine group goes from 56 to 70%, and the overall survival goes from 70 to 79%. So there was a significant increase in DFS and OS. Criticisms of this study: it's the only study that we have in this setting. It was only in a Japanese population, so is that translatable to the UK population? There has been some adjuvant studies which have had some mixed data. So for some, the jury is out. I'd have to say for us, because we know that if those patients that don't achieve a PathCR are going to do so badly, we do chuck capecitabine in. It's not for everyone. Some people have just done 6 months of chemo and a big operation, and they just really can't be handling anymore. But it should be considered part of the standard treatment pathway now. So to summarize, have your choosing to find young women who are young, fit women, bigger cancers, node positive, I would certainly be escalating them. And the options there would be accelerate the chemo, so give some of it 2 weekly, or add carboplatin to EC Taxol. And if that doesn't achieve your PathCR, you can then also add capecitabine adjuvantly. In the future, we may be in a position to think about immunotherapy as well, but that's not available yet. In terms of de-escalation, the main thing is if you've got an elderly patient or somebody with comorbidities, and this is a clinical call that you need to make, I would give the chemotherapy adjuvantly rather than neoadjuvantly. You've got a couple of options in terms of either, reduce the dose of the EC, or you could bin the EC if you don't think you're going to get away with it, and you give the Taxol weekly and see how they get on with that. A very quick case, I was referred this lady the first sort of week of March or something, just as COVID was going nuts, and she was so she'd been through the MDT, she had a big cancer, lots of lymph nodes, and so the surgeon said, well, obviously she's for neoadjuvant chemotherapy. And I see this lady and she's 82 and she's got comorbidity, she's got early dementia. I'm thinking, there's like COVID or no COVID, there's absolutely no way I'm going to get this woman through 8 cycles of EC Taxol. She's going to fall to bits. And the thing you've got to be really, really careful with neoadjuvant chemo is your nightmare is that they become really sick or get wiped out or, get COVID or whatever else it is. And then they're not well enough for their operation, because then what you've got is a woman who hasn't had proper neoadjuvant treatment, has their operation delayed, and has a big cancer that's still just sitting there not being treated. So young for some people would be physically young. It's really, when you're giving someone neoadjuvant chemo, you need to be clear that they are going to be able to get through it, because you do not want to get stuck in a situation where you have to abandon it halfway through because you've made them more unwell and you've delayed their operation. Okay, moving to HER2 positives. You'll remember this is another one where the PathCR really relates to prognosis. So in high-risk patients, we would want to escalate them. The HER2 pathway, therefore, comes down to the MDT, and your first decision is this someone that I'm going to do the surgery first and therefore de-escalate, or is this someone that I want to escalate and give neoadjuvant treatment, because then I can escalate them with additional HER2 therapy? And that decision, again, will be based on clinical risk factors. So the size, anything, you wouldn't escalate for a T1, you would escalate for T2 upwards, node positive, high grade, and you might consider the ER status. So I'm going to start with de-escalation first. So this is a study, it's a single arm phase 2, but it had, 700 patients or so in it. Essentially what the clinicians did was they decided who was low risk, and they were pretty much all T1 cancers, so 2 centimeters and below in pretty much all of them. They then de-escalated the chemo, so they gave just the taxane and no anthracycline, so just 12 weeks of chemo and 12 months of Herceptin, so no pertuzumab. And when they followed them up for 7 years, 93% of them were alive and well. So even though it's a non-randomized study, there's no randomized arm that's going to do better than 93% in HER2 positive breast cancer. There was a little bit of a suggestion that maybe the ER positives did slightly less well, but they were still sitting with a 7-year disease-free survival of 91%. So essentially, if you have patients coming through the MDT who have a smaller cancer, certainly an ER positive cancer that's less than 2 centimeters and node negative, I would be asking my surgeon to operate, and I'd be considering them for a de-escalated chemotherapy regime, the APT regime of 12 weeks of Taxol and Herceptin. I haven't put in the Persephone study here. There was also a trial looking at 6 months versus 12 months of Herceptin, which showed that it was non-inferior. So that's also an option. But to be honest, I think most people have decided to cut the chemo rather than cut the Herceptin, just in terms of the toxicity. For those patients that you want to do more, so that would be the patients that you would refer for neoadjuvant chemotherapy, because then you use 2 HER2 antibodies. So you've got Herceptin with so trastuzumab with pertuzumab. So we've heard the metastatic data Alicia described in the Cleopatra study, and ignore these 2 at the bottom. But essentially the top 2 arms were docetaxel with Herceptin alone or with dual antibodies. And you can see the uplift in PathCR rates there. we've also got results from the Trifina study, which is shown on the right, where everybody got dual antibodies. That's why everybody's PathCR rates are around 50% or above. The point to make here is that in the ER/PR negative HER2 positive breast cancers, those are the most chemosensitive. They're the most likely to achieve high PathCR rates, whereas the ER or PR positive HER2 positives are slightly less chemosensitive, although they still do far better with the combination with dual HER2 antibodies. And this is now standard of care and has been for some time and is NICE approved. So those higher risk patients, we will give neoadjuvant chemo plus dual HER2 antibodies, but what about those who don't achieve a PathCR? So again, there's this idea of escalation to another drug rather than just continue what you're doing, move to something else. And this only got approved in the middle of COVID. So those of you that haven't done breast cancer for a while probably won't have had access to this. This was the Catherine study, super busy slide. All you really need to know is they were patients who had residual disease. I'll say, here we go, residual invasive disease after neoadjuvant treatment, and they were randomized either to your standard complete the year of Herceptin or complete the year with TDM1. And these were practice changing results. So you've got invasive disease-free survival on the left, freedom from distant recurrence on the right, TDM1 in blue, Herceptin in red. And what you can see here is a very clear difference with a hazard ratio of 0.5, statistically significant. What this tells you that is in ER positive early breast cancer, if they have invasive disease after they complete their neoadjuvant therapy, then if you give them TDM1 versus continuing on Herceptin, you reduce their risk of recurrence by 50%. So that is practice changing data. And as I've said, this got through the funding program. And so this is now available for NHS patients as of, I think it was April time. I'm not 100% sure that with everything that happened with COVID, that everyone has quite got their ducks in a row with this. But if it's not available where you work, I would maybe quietly ask why that might be, because I think that, you know, the other thing that this has done is give us more of an incentive to maybe do neoadjuvant, because having this PathCR data, there's something that we can do about it now. So it offers people the opportunity to have TDM1. So the HER2 pathway, I think this used to be really easy and now it's really complicated. You used to say to people, right, you're going to get Effecti and a year of Herceptin, and that was it. Whereas now you're sort of saying, well, we use Taxol, but you're sort of saying, you're going to get a year of anti-HER2 therapy, but I can't actually tell you which drugs. So essentially what happens is you get your chemo with your dual HER2 antibodies, and then they have their surgery. At the MDT, you will see whether or not they've had a complete PathCR. If they have, then if they were node negative at the outset and there's still no fibrosis in the node, so we still think they're node negative, then you stop the pertuzumab and they just get subcut Herceptin for the rest of the year. So their anti-HER2 therapy will be completed with Herceptin alone. If, however, they were node positive at the outset, or when you look at the notes, you see evidence of fibrosis, so there were nodes there and they've been killed by the chemo, then you get 2 antibodies for the rest of the year, Herceptin and pertuzumab. That's the affinity study if you haven't, if you want to look it up. However, if they did not achieve a PCR, then you stop what you're doing, stop the HP and switch to TDM1, and you continue that till the end of the year as per the Catherine study. So to summarize, early breast cancer and HER2 positives, I would de-escalate and give adjuvant treatment for people with a cancer less than 2 centimeters who are node negative, and look at the APT regime. You might want to consider 6 months of Herceptin instead. If you're escalating the bigger tumors, certainly the node positive tumors, you give neoadjuvant chemotherapy with dual HER2 antibodies. And then what you do in the adjuvant setting will depend on whether you get a PathCR or not. So if node positive, just Herceptin. If they're node negative, just Herceptin. Node positive, dual antibodies. You can see it's complicated. And anybody who doesn't get a PathCR, stop what you're doing and switch them to TDM1. So a couple of very quick cases. That's fairly simple in theory. You'll get a couple of cases through the MDT where it's like a lady over 70, her cancer is smaller than 2 centimeters, she's node negative. That's fine. That's definitely APT territory. I would say de-escalate. She can have surgery, Taxol, Herceptin, no problem. Equally, you'll have young patients through who've got bigger cancers that are node positive in grade 3, where it's very obvious that you should escalate. You should give them neoadjuvant chemo, and if they don't get a path-CR, you'll switch them to TDM1. But there will be those people that are a little bit in the middle, who are sort of around that 2 centimeter mark. So 65 for me is still young. It's only 25 millimeters. It's not that far off 20 millimeters, and it's a grade 2 cancer, not a grade 3. It's strongly ER/PR positive. Does she really need neoadjuvant chemotherapy, or can we get away with 12 weeks of Taxol and Herceptin? Equally, a younger patient who's got a small cancer, 21 millimeters, that's very close to 20, but it's grade 3. Yes, it's node negative, but that was supposed to be ER4, PR0. So she's less chemosensitive. She's more of the slightly more aggressive subtype. Are we happy de-escalating her, or does she want to get neoadjuvant chemotherapy on a 21 millimeter cancer? And I think it's those sort of middle of the road ones where you will find that different consultants will be more or less prone to push for neoadjuvant treatment. Equally, just remember, if you've got, this is an elderly woman who's got a big node positive cancer. But again, if you don't think that she's going to get through EC and 12 weeks of Taxol HP, then don't do it. Then still say to the surgeon, in terms of her physical fitness and her ability to withstand neoadjuvant treatment, I would think you're better to have the operation first, and then you can give the chemo adjuvantly with dual HER2 antibodies if they're node positive, and you won't run into the problem of her falling apart on chemo and getting stuck unfit for an operation. Okay, so lastly, a little bit of a romp through ER positive breast cancer. So not really talking so much about the endocrine, but this is the group in where we've got these, I've written Oncotype, but essentially we're using, they're all available now. So you could use Prostigna, you can use EP-Clin. And when you're looking to de-escalate, we're looking for reasons to omit chemotherapy. So if they're node negative, these tests have been available through NICE for some time. And if you've got low risk test results, then we know that the prognosis for these patients is good, so you can omit chemo. There will be, with these genomic tests, you do get still this intermediate group. So some people are sort of scratching their heads and just sort of giving less chemo if they fall in the middle. But you would still want to escalate if you've got those same clinical risk factors, grade 3, node positive, you've got a high risk genomic test. And your options still lie between accelerating the chemo, but you can't really add anything on at this stage. So your only other option is to extend the endocrine therapy. So you'll know that we're now giving 10 years of endocrine therapy, particularly for anything that's over 2 centimeters or anything that's node positive. In premenopausal women, we'd also be considering the addition of ovarian function suppression for the first 5 years. So although we can't add anything yet, the question of the CDK4/6 inhibitors, which again you heard about from Alicia, been so successful and groundbreaking in metastatic disease, will they make a difference in ER positive breast cancer? Well, we all thought so. And so it was with great interest that some of us actually tuned in on the weekend to the ESMO data that was recently presented. I'm just going to present the positive study in the interest of time, which was using abemaciclib. So it's adjuvant abemaciclib. So this is a high risk population. So people who've completed their adjuvant treatment, nearly all of them had neoadjuvant or adjuvant chemo. And then those people who had at least 4 lymph nodes involved, or 1 to 3 lymph nodes with additional risk factors, so big cancers or grade 3 or high Ki67, they either got standard of care endocrine therapy or an addition of abemaciclib, which is one of the CDK4/6 inhibitors. In addition, they got 2 years of abemaciclib. Very brief romp through of the headline data, which was when at the first presentation of the data, it's an early review of the data, but at first presentation of the data, this was the primary endpoint, invasive disease-free survival. And there was a statistically significant difference, which you can see the p-value there. In absolute terms, it was a 3.5% difference in IDFS at 2 years, with those curves beginning to separate at 9 months. So we will hear more data from this drug. The PALACE trial, which looks at palbociclib, was negative in the adjuvant setting, but we are still what will still be interesting is that third drug, ribociclib. The trial is still ongoing, and they've done they've actually given the drug for a bit longer. So lots and lots of stuff will be coming out about the adjuvant CDK4/6 inhibitors. So not there right now, but I think almost certainly will be in the future. So there's a very complicated summary slide that I will leave you to digest. And in the meantime, I will take any questions. Thank you.
Thanks, Dr. King. I think that was a great overview. I think there's lots going on in breast, obviously, in both neoadjuvant, adjuvant, and in metastatic, so lots to digest. There's quite a few questions coming in.
Oh, I was supposed to do neratinib. I really just couldn't face it. So Sarah, the adjuvant bisphosphonates for that's postmenopausal women only. It is detrimental in premenopausal women unless you shut them down effectively with Zoladex. And we would give them in high risk, which essentially for me means if they're high risk enough to need chemo, then they get Zamita 2 following a dental review. Oh, neratinib. Okay, so the Externet study is just the biggest dog's dinner study you'll ever see. People sort of going onto the study, they shut it down, and then the drug changed hands and was taken over by another company, and they phoned up all the trialists and said, can you please go and get your patients and phone them up and see if they're still alive? It was an absolute mess. But what essentially it showed was that if you added neratinib, which is an anti-HER2 tyrosine kinase inhibitor, there was an improvement seen in particularly the ER positive subgroup. So it is currently available. Let's remember, it's available for those, well, where we would use it is those patients that did not achieve a pathological complete response after their neoadjuvant treatment and are ER positive. So, and because you can start this drug within, I think, the first year or after they complete their Herceptin. So we do still have some patients. In fact, I think we started one of our first patients in the last couple of weeks. So if you had a patient who was treated way back in the day, they might still be on their adjuvant Herceptin now, and TDM1 wouldn't have been available. So you might still find some patients coming through for a bit who would therefore still be eligible for neratinib. It's a tricky drug to use. There's a lot of diarrhea, but I suppose for patients who do have a residual cancer burden, it is certainly an indication. Alicia's probably used it more than I have in the compassionate access program. Alicia, have you got anything to add?
Yeah, I mean, I agree with TDM1 now. It's not really going to be something we'll be using in general, but there are a few patients. But what I found is that women really struggle with it in the adjuvant setting in a way they don't so often in the advanced disease setting. I think if you've completed your year of Herceptin, you have to be incredibly motivated then to take your neratinib after that. And yeah, we've had the odd one go on it and the majority don't complete the treatment. So I think my personal feeling is that this will die a death, actually. Yeah. And the whole, as you say, the trial was a bit of a mess, and why was it only positive in ER positive women? It just doesn't quite make sense to me. So I've never been a big fan in that indication.
Sophie's asking about extended adjuvant. So it's a big talk for another time, but to cut a long story short, there's a big meta-analysis showing that the benefit is seen only in cancers greater than 2 centimeters or node positive. So I'm definitely offering it to node positive patients and bigger cancer, so 2 centimeters up cancers, if they're tolerating it all right, because there isn't a survival benefit. And the other thing you need to think about is if someone's 82 when they start their treatment and you give them 5 years of treatment, then they're 87, they probably don't need another 5 years of endocrine therapy just so that they live past 100. So you need to think about their age when you start. Is CAPE NICE approved in the adjuvant setting for triple negative? Yes, it is. So we would count that as standard of care now, Ashley.
And just to finish then, Judy, I've got a question for you. So you mentioned the chemotherapy and IO in a neoadjuvant setting and the toxicity that comes with that. Do you think by adding immunotherapies in that perhaps we can kind of scale back on the chemotherapy?
No is a quick answer. So I think that people are very comfortable with the neoadjuvant chemo and understanding the toxicities. I think people would, if especially in triple negative, you're seeing that uplift to sort of 50% of patients getting a path-CR with EC carbotaxol. I think people would be very loath to try and drop that down, because if you drop the chemo and make up for it with the IO, why would you want to drop it in the first place? So I think it's going to be a question of doing more. but very much, if we can, identify those people that need it, because there's about 20% of people that just get a path-CR in the first 12 weeks with the taxanes alone. So not everyone even needs the anthracycline, but there's some that will need the anthracycline, some that need the carbo on top, and some that need the immuno on top. And if only we could pick out who needs what, we would be onto a winner, but it's a lot harder than it looks.
We'll move on to the trainee case presentation. So first of all, we've got Florence Chamberlain, who's a trainee based at Barts. So Flo, as soon as you're ready, you can start sharing your slides.
Hello everyone, I'm Flo, I'm one of the registrars at Barts, as Dan mentioned. I'm going to talk to you about a case that I saw when I was on my breast rotation at Barts. So this was a 55-year-old lady who in 2017 was diagnosed with a localised inflammatory breast cancer, T4N1M0. She was treated with neoadjuvant chemotherapy with Docetaxel, which she completed. She then went on to have her mastectomy and node clearance, and the final path, she had a T4D-N1M0 ER positive HER2 negative breast cancer removed. She completed adjuvant radiotherapy to her chest wall with a boost and some adjuvant letrozole with 6-monthly Zometer. Unfortunately, in May 2020, 3 years later, she presented via the one-stop clinic at Barts with a parasternal mass. This was biopsied and a CT scan showed metastatic disease in the liver with some low volume bone disease in the vertebral column and in the iliac crest with a small pleural effusion. And that biopsy that had been performed confirmed this was metastatic ER positive HER2 negative breast cancer. So she was started on palbociclib, full dose with fulvestrant with 4 weekly denosumab as per our policy, and on day 15 she came in for a blood test, and as you can see from the slides, her blood counts had significantly dropped with platelet count of 32 from a normal baseline and neutrophil count of 0.3. The rest of her blood tests, other than her tumour markers, were unremarkable. Her haemoglobin had also dropped. We checked her hematinics and they were normal. So we held her palbociclib, and as she was feeling well, kept on her on regular symptom surveillance with telephone calls and 3 weekly blood tests until she recovered. So just a quick poll, if that's okay, if that can work. What would you do next in terms of her treatment if you had that blood picture in front of you? The options are either to stop the palbociclib but continue with the fulvestrant and the denosumab, dose reduce the palbociclib and continue the fulvestrant and the denosumab, change her to chemotherapy, dose reduce her palbociclib and stop the fulvestrant, or continue the palbociclib, fulvestrant and denosumab as per cycle 1. There's no wrong answers here, really. Dan, can you, are we, yeah, perfect. Okay. So most people said dose reduce the palbo, continue with fulvestrant and denosumab. Oh, not working. Dan, I can't do the, here we go, perfect. Yeah, so we agreed and we resumed her treatment, reduced the dose to 75 milligrams, which is 60%, and monitored her really closely. And she was doing reasonably well. Her day 15, cycle 2, day 15 bloods were reasonable, but unfortunately she sort of collapsed on day 19 and was admitted to via A&E with a symptomatic anemia. She required a blood transfusion. Obviously the palbociclib was held for the remaining couple of days, and she was eventually discharged the next day with regular blood tests and symptom surveillance. So bear in mind those what's happened in cycle 2 and cycle 1. What would you do next? So the options are either stop the palbociclib, continue the fulvestrant and denosumab, switch her to chemotherapy, or continue the palbociclib, fulvestrant and denosumab at the same doses as per cycle 2. Okay. So interestingly, most people said stop the palbociclib, continue the fulvestrant and the denosumab. And so we actually had a departmental meeting about this lady, and in the, oh, sorry, I can't move my slide on. Sorry, Dan. There we go. So we actually decided as a department to continue her on the treatment with the 60% dose reduced palbociclib with the same doses, obviously, of denosumab and fulvestrant, because her blood counts, they came back up again after stopping the palbociclib, and the reason for discussing this case was actually quite difficult to tell whether or not this was disease that was causing her blood counts to become so suppressed, or whether or not it was the palbociclib. And as we've heard from Dr. Okines, you know, neutropenia is a very significant toxicity with palbociclib, and we just decided, you know, we're going to crack on, give her the treatment and the benefit of the doubt, and organise a scan towards the end of her third cycle to reassess things. Unfortunately, she actually presented around day 15 with chest pain and breathlessness, ended up getting a CT scan which confirmed some disease progression, and the patient stopped palbociclib and fulvestrant and switched over to Paclitaxel. And actually, when we did her tumour markers at that time, they had jumped up to 550, having previously slightly fallen with the start of treatment. So this was a very challenging case, as you can see, balancing the toxicity of the palbociclib. She did have bone disease known about, but it wasn't large volume bone disease to account for the neutropenia and other bone marrow toxicity that she was experiencing. So that's my case, and I'd be grateful for Dr. King and Dr. Okines if any comments or questions that anyone has on this case.
Thanks, Flo. I mean, I think Alicia and I made a similar point about abemaciclib. So it may not have been available because palbo was available first, as sometimes it wasn't there to switch to. But you do, it's not normal that you get a real pancytopenia like that, but we've all seen the odd one where the platelets just tank, and you're thinking, you know, there's going to be so many delays and restarting, and sometimes you end up on sort of 75 milligrams alternate weeks with sort of homeopathic doses. I think you've just, that's a case when I would switch to abemaciclib. The grade 3 neutropenia rate is 20% versus 50% for palbo and ribo. So certainly abema would be a strong contender here.
Someone's made a good point on the chat as well as to whether this might have been marrow failure, and that's exactly what we have to look for in this situation. If your counts come up nicely, as they should do within a week or so of stopping the palbociclib, it's less likely to be due to the bone disease. And actually, this was a lady who at the outset had a single focus of bone disease, so it's not the sort of patient you'd expect it to be marrow infiltration, but as you saw, she progressed, so it could be. But you're exactly right. So you'd think about a bone marrow biopsy if someone wasn't recovering their counts, and at that point, you most likely need to switch to chemo. But if they bounce back up again within a week or even 2 weeks, then it's probably actually just they're particularly sensitive, and the dose reduction is the right thing to try first. I mean, you actually did a double dose reduction. Normally, with grade 4 neutropenia, I would have just done a stop and wait and restart at 100, but you obviously made the right decision because she was very pancytopenic after with the 75 dose, but it's unusual to need to do a double dose reduction like that. Would normally just go down one level unless someone was flat for a really long period of time, and again, you'd be thinking marrow at that point.
Yeah, so the other thing, well, from our department, I mean, we, going back to your comment about the 3 different CDK4 inhibitors, in our department, for sort of ease of management, really, we've kind of gone for palbociclib as the main CDK inhibitor, just so that kind of helps with the juniors like myself and the CNSs to help manage toxicity. So I think the majority of our patients are having palbociclib rather than ribociclib or abema.
Yeah, I'm the same. Oh, that was weird feedback.
And yes, so yeah, there was a question about the ALP to be abnormal, about bone disease. You know, so that the bone profile and everything, that was the liver function, and everything was completely plumb normal throughout the first 3 cycles. Really, she just it was only the bilirubin on cycle 3, day 15 that went up, and that was the only indication. And obviously, when she'd had the scan for acute breathlessness, that we realised that, you know, she'd progressed.
And Alicia, you mentioned giving the patient a week or so to recover. Is there a kind of platelet level, blood level you want to come up to before restarting onto a different course?
Yeah, I mean, ideally platelets above 75 and neuts above 1. I mean, you know, if your neutrophils are 0.9 something, they're probably going to be fine, but that's generally a consultant decision, and this lady might not be. But for the majority of patients who've been ticking along quite nicely, if their neutrophil is 0.9 something, if you get them to walk up and down stairs, it'll be 1 point something. So it really is somewhat irrelevant. But yeah, the platelets are obviously important. So a week or so to come up, and if they're taking longer than that, just start getting suspicious about the bone marrow. I've had patients who've taken a couple of weeks to recover and have been fine, but they don't always. You certainly need to watch them, as Flo said.
Okay, great, thanks very much. That was a really useful discussion. We'll now just move to the next trainee case presentation. So we've got Dr. Rachel Broadbent from Manchester. So Rachel, when you're ready, you can share your slides.
Okay, thanks for having me to present. I'm a trainee based at the Christie Hospital in Manchester, and this case is a case of an unexpected pregnancy in a woman with metastatic breast cancer. So this is a 29-year-old woman with a 6-month history of a left breast lump, and she had no past medical history. She lived with her partner and her 5-year-old son, and they had no plans for further children, and she was not using contraception at the time. Diagnostic and staging investigations revealed an invasive ductal carcinoma of the left breast, and triple assessment revealed that she had a T2 cancer with axillary node involvement that was ER negative, PR negative, and HER2 positive. Unfortunately, further staging revealed that she had liver metastases on her staging CT scan. So based on that finding of metastatic disease, she commenced treatment with docetaxel, pertuzumab and trastuzumab, and happily her first scan confirmed that she was responding to the treatment. However, docetaxel was discontinued after cycle 4 due to radiological evidence of bowel perforation, which she was asymptomatic of, and she continued on maintenance pertuzumab and trastuzumab. The next scan showed ongoing response in the liver, but a new pulmonary metastasis. However, at that point, after that scan, she continued on the maintenance therapy because she was benefiting at that point. So after a total of 7 cycles of pertuzumab, trastuzumab, she reported being amenorrheic for 6 weeks, and a pregnancy test was positive. And so at that point, a scan confirmed that she was 7 weeks pregnant. So she had a joint consultation with her medical oncologist and obstetrician, and the risks to both her health and the health of the fetus in continuing with the pregnancy in her situation were explained. However, she wanted to continue with the pregnancy. And so following an MDT discussion, the antibody therapy was discontinued. And you'll recall she was no longer receiving chemotherapy at that point. So she continued having surveillance with clinical examination, blood tests, and it was advised that she should undergo an MR liver without contrast to monitor the disease. And she was seen in the oncology clinic at weeks 19 and weeks 25 of pregnancy. And at those times, the fetal scans were normal. However, at week 25, it was seen that she had progression of her liver metastases. And so at this point, she commenced chemotherapy with 3 weekly cyclophosphamide and epirubicin. This went relatively smoothly, and she stopped treatment at week 34 of pregnancy and underwent a planned caesarean section at week 38. 4 weeks postpartum, she underwent further restaging, and the CT scan showed evidence of disease progression in the liver, and therefore she recommenced trastuzumab. And so it's a relatively quick case, so we're going to have a little quiz. If Dan can bring up the polling, please. So the first question is a slight test of how well you've been listening, because this has been discussed in the first talk. And the question is, how much did the addition of pertuzumab to docetaxel and trastuzumab improve overall survival in the Cleopatra trial? And the options are 9 months, 16 months, 20 months, or 24 months. Okay, so we've got lots of answers coming in, and happily everyone has been listening, and the answer was 16.3 months. And so as I mentioned, this was the Cleopatra trial that was discussed earlier, and the median overall survival was 40 months with placebo, 57 months with the addition of pertuzumab, and the 8-year overall survival was quite impressive, with 23 versus 37%. So on to the next question. After what point in pregnancy is it safe to deliver chemotherapy? Is it 25 weeks, 14 weeks, in the 3rd trimester, or never safe to deliver chemotherapy during pregnancy? So we've got quite a variety of responses there. Now the answer is 14 weeks. And so essentially after 14 weeks, the crucial period of fetal organogenesis has been completed. And so there's no evidence that giving chemotherapy after that point in pregnancy causes any compromise to fetal development. And it's considered to be generally safe, although there is an increased risk of premature delivery. And the third question is a true or false question. Taxanes can safely be delivered after the 1st trimester. True or false? Okay, and so the answer is true, although there is less evidence for taxanes as compared with the anthracyclines in either epirubicin or doxorubicin. There is, I believe, a consensus that you could use taxanes after the 1st trimester if required. And question 4. Regarding risks to the fetus, which one of these statements is false? And so just to be clear, which one of the statements is false? Is it, firstly, oligoanhydramnios is a common complication of fetal exposure to trastuzumab in the 2nd or 3rd trimester? I'll just read out C. Oligohydramnios is a complication of fetal exposure to trastuzumab in the 1st trimester. Or is it that the mean gestational age at delivery after exposure to trastuzumab is 33 weeks? So which one of those is false? Okay, and so the answer is actually C. And so it's actually the case that oligo or anhydramnios is a common complication of fetal exposure to trastuzumab, where that fetal exposure has occurred during the 2nd and 3rd trimester, and there's no evidence, in fact, that it would complicate a pregnancy where the exposure occurred in the 1st trimester, as it did in this case presentation. And the reason for that is that it's thought that the effect of trastuzumab on the fetal kidneys causes the oligohydramnios, but the fetal kidneys only become responsible for production of amniotic fluid after 4 months of gestation. So that's the underlying reason for that. And so the final question is, to avoid early spontaneous labour, delivery of chemotherapy should be withheld from which time point in pregnancy? And is it 30 weeks, 34 weeks, 35 weeks, or 37 weeks? Okay, so the answer is 35 weeks of pregnancy, and so you're not just avoiding early spontaneous labour, but you would also want to avoid labour occurring during the nadir in terms of blood counts following the chemotherapy. So the answer is 35 weeks, and that's the last question. So it's the end of my slides. Thank you very much.
That was great, Rachel. Thanks very much. Any comments to add to that from the panelists, Judy, Alicia?
Yeah, pregnancy and breast cancer, always a nightmare, even in the adjuvant setting, but certainly in the metastatic setting, it's really, really, my one take-home message here is, I mean, you saw how poor the responses were in terms of accuracy. This is phone a friend time. This is stuff that only happens to those of us in the field not very often. So it is absolutely time to pick up a phone. And if you don't have anyone to phone, then you can phone me, because I inherited the breast cancer practice from a colleague called Alison Jones, who had a specific interest in breast-associated cancer in pregnancy. And so I've done quite a lot of it, and we still don't see that much of it. We actually do it a bit differently. I would have given chemo through most of the pregnancy. We take it up to sort of 37, 38 weeks very happily if you're doing weekly Taxol, because you've got weekly bloods. You're right. The one thing you really don't want to do is to have someone have a crash C-section with like neutrophil counts in their boots. But that doesn't really tend to happen if you've had them on weekly Taxol forever. You know what they're going to be doing. So if they're absolutely fine, they'll be fine at 38 weeks too. They do quite often deliver early. We've had that a lot. You need to be speaking to your obstetrician. So we have a system where they kind of go to their obstetrician for their growth scan and then come down to their oncology appointment. But this, I mean, it's always, the last one I did was a midwife. It was just, you know, it's always really, really difficult.
Yeah, completely agree. Total headache, poor thing, really difficult, lots of emotion involved, and phone a friend, and also keep your pharmacist close to hand, because once they start getting nausea and side effects, obviously there's lots of medicines you can and can't use. So just keeping an eye on all of that as well alongside the chemo. It's very hairy, and it's a great moment when the baby comes out okay.
That's great. Thanks very much, everyone, for contributing. Any final comments before we close?
Make sure you tell your patients to use contraception during chemotherapy, because that, and I think that one ended well, but often ones like that don't, and it just adds massive stress to the situation for the poor patient and family. So just remember, when you're consenting, do talk about contraception. Yes,
that's a really good point to end on. It is. So we now have standard national chemotherapy consent forms, which if you're not using, you should look into the SACT chemotherapy from CI UK. But yes, if you can't be good, be careful.
That's great. And I think that's probably a good point to end the session on. Thank you once again for everyone for attending this evening's ACP webinar, especially to our speakers, and thank you for the time. Thanks very much again, and we hope you enjoy the rest of your evening.